So like I was saying, how to deliver an infant, any complications during pregnancy, after pregnancy, with the basic anatomy. So what do the ovaries do? Carries eggs. Okay, releases eggs. What about the fallopian tubes? Yeah, it's where the egg travels. The uterus. Yeah, that's where the fetus develops. It's also like a muscle, so it's a pretty good environment for a fetus to develop. It expands and contracts, which is really important, right? Because we don't want the baby to be formed in any other part, because that could be considered an ectopic pregnancy. But we're going to talk about that later. We also have to be aware of the position of the bladder and then the rectum. That's really important once we talk about delivery. I don't know if you guys have heard that most women that deliver, they feel a need to defecate, which this makes a lot of sense, because as this expands, it puts a lot of pressure on other organs around the body. What else? Yeah, overall, the only new organs and structures that are developed in an obstetric patient is what? What do you think those organs are? Organs or structures are? I'll give you a hint. Well, one of them's the umbilical cord. The placenta.
And then it's not an
the
organ,
baby.
but like
but the
baby itself.
Yeah, the amniotic sac and the fluid, right? The cord, and then also the placenta, of course. What does the placenta do?
It gives nutrients to the baby.
Nutrients to the baby. So one important thing also to note is that whenever we're talking about the blood of the baby versus the blood of the mother, those aren't mixing. The only thing that happens within the umbilical cord and the placenta is that that's where gas exchange occurs and nutrients are transferred. So blood isn't mixing between the baby and the mother. That's really important to note. I didn't know that either until I took this class, because I always thought that the blood would mix, but it's actually the nutrients and the oxygen. And then whenever the baby releases the CO2, it gives it to the mother, and the mother oxygenates it for the baby. So. Wow. So also with the menstrual cycle, so for most women it lasts an average of 28 days, but again it depends. Day 1 starts with menstruation, so the period, and that's whenever estrogen levels and progesterone levels are low. Whenever a woman is ovulating, that's whenever the progesterone and the estrogen levels rise, which makes it a very desirable environment for implantation to occur, fertilization. So that's whenever the woman is most fertile. But it's just really important to note that menstruation is day 1 of the whole menstrual cycle, which lasts 28 days. And then this graph kind of explains it a lot more. So day 1 is menstruation. As you can see, there's shedding of the uterus. After about 6 days, depending on how long the period lasts, the uterus starts developing, building up more until ovulation, where you see a peak in estrogen and progesterone levels. Then once it gets up here, that's the complete building of the uterus. And then after day 28, starts again at the period, or the menstruation. Let me know at any time if I'm talking too fast, or if you're not understanding, if you want me to explain it again, or like any questions and stuff. So the pre-embryonic phase is the first 14 days, so that's whenever you would call the baby an embryo, up until 8 weeks. And then the fetal stage is from 8 weeks to birth, and then the neonate is another word for an infant. Those words are used interchangeably in exams and in your book, so just know that neonate is another word for infant. And then the pregnancy lasts 280 days, which are divided by trimesters. So each trimester is 3 months, and so we have first trimester, second trimester after 6 months, third trimester after 9 months, and that's normally the length of it. Average is like at least 38 to 40 weeks. That's the maximum amount of weeks of pregnancy. But then again, it depends, and we're going to talk about premature deliveries and overdue. So the uterus, like I said, it's a muscle, right? It expands and contracts, and whenever a woman becomes pregnant, the uterus becomes a sixth of the mother's blood volume. So there's a lot of blood that's going to be produced, and we need this in order to form the baby. Another thing is a mucus plug forms in the opening of the cervix. This is going to prevent any bacteria or infections entering the mother's cervix into the uterus. Another thing is that the breasts are going to enlarge to prepare for lactation, or the development of breast milk. Some changes in the anatomy and physiology also is the respiratory system. So why do you think that there's going to be an increase in tidal volume in a pregnant woman?
Because they need extra oxygen for the baby.
Yeah, so they're going to need a lot more extra oxygen to be able to deliver to the baby. Another thing is that you're going to see an increased respiratory rate, so don't be alarmed if when you're taking vital signs, they're breathing a lot faster than a normal patient who is not pregnant. Same thing with the cardiovascular system, increased maternal heart rate by at least 10 to 15 beats per minute. The blood pressure is going to also increase slightly, but then it's going to return to normal after during the third trimester. Then like we said before, her blood volume is going to increase by 45%. So when you're taking vitals, make sure to remember that everything's going to be a little bit more elevated. For the musculoskeletal system, it makes sense if you have a very heavy, you're carrying a lot of weight, your center of balance is going to be a little bit off, so you're going to be, there's going to be some joint pain that the woman's going to be experiencing, back pain. Also, the pelvic joints are going to loosen up because of the hormone production, so just note that. It makes sense. Sometimes you usually hear women that are pregnant complaining about the pain, especially once they get later closer to their delivery date. There's going to be a lot of pain, and it's going to feel very heavy. For the GI system, especially during the first trimester, you're going to see a lot of nausea and vomiting or morning sicknesses. That's just the fluctuation of level of hormones in the woman's body. Bloating and constipation. For the urinary system, increase in frequency of urinating, and also whenever the baby is expanding in the uterus, what happens is that all the organs, or most of the organs, are going to be pushed up and out, so that's going to put a lot of pressure on the urinary bladder. Another thing is that you have to also be aware that because the bladder is going to be more in a way exposed, because it's coming up and out, there could be an increased risk of injury. So we have to really be aware and careful whenever we're assessing a female patient. So for patient assessment, it's pretty much the same thing. We want to focus a lot on ABCs. Well, we can start with scene size up. So, the usual patient assessment. Just know that a female patient between the ages of 12 to 50, you can assume that there could be a pregnancy there. So 12 years old, the start of puberty. 50 years old is usually whenever the woman experiences menopause. So just know that between those ages that there could be a chance of pregnancy. For primary assessment, so again, airway, breathing, circulation is really important. Taking note that all the vitals of the woman are going to be a little bit elevated, especially once they get to the later stages of pregnancy. You're going to see that the skin's going to be a little bit more flushed. They usually call it the pregnancy glow. It's like a mixture between happiness and then also they just have an increased blood volume in their body. So with sample and OPQRST, I'm sure you guys remember the questions with those, right? We're going to talk about some other questions that you need to ask the female patient. So I'm just going to read through these. So have you ever been pregnant before? If so, how many pregnancies have you had? So this is really important because this is going to determine whether or not this is going to be a fast delivery or a slow delivery. If this is the female's first pregnancy and she's experiencing a lot of contractions, and we know that she's probably going to be in labor for hours compared to a woman who this is her 6th pregnancy. The time between labor and delivery is a lot shorter for a woman who's had more babies. So remember these terms a lot because they show up a lot in the National Registry. I remember in the OB section they had that question and I completely forgot what those were. But it's para and gravida. So the number of pregnancies is gravida, and then how many pregnancies resulted in live births, para. So the way that I remember it is para, people. How many people do you have? How many children do you have? And then gravida is just the opposite of that, how many pregnancies you have. And so I guess some practice, if it's a para 0, gravida 1, what does that mean?
One pregnancy, but
No.
This is my first pregnancy of like all time.
Yeah, this is the woman's first pregnancy. What about, because para 0, so she doesn't have a child yet, but she is pregnant, gravida 1. Para 5, gravida 6, what is that?
This is her 6th pregnancy.
Yeah, 6 pregnancies. She already has 5 children. She's waiting for her 6th one. So more questions that you want to ask if they've had any unusual vaginal discharge. That's very important to know, especially if it's blood or any other fluids that are green or yellow, things like that. Ask the patient if she knows when she's due and if she's had any prenatal care. This gives us an idea of what we're going to expect whenever the baby's delivered. If the woman hasn't had any prenatal care, there could be a lot of increased risk of complications with the pregnancy, with the baby. A lot of the times the woman just can't afford health insurance, so she completely doesn't even go to her OBGYN. So we have to kind of paint a picture of what we're expecting with the patient when we ask these questions. For the pain and discomfort, we really want to be as detailed as possible of where the pain is located, what kind of pain they're having, kind of pinpoint where the pain is localized, if there's any radiation, quality of the pain, normal questions that we usually ask patients experiencing any type of pain. So for the secondary assessment, this is where we do the head-to-toe examination. We want to palpate the abdomen, but be very careful, of course, the woman's pregnant. Baseline vital signs, like I said before, everything's going to be elevated. So it's pretty much the same thing, patient assessment. I don't think we really have to go over everything in detail. I kind of just summarized everything, because you guys should know medical assessment by now, right? Or at least, sort of. For the bleeding of the vagina, so we don't want to pat anything inside. We just kind of want to gently, apply a little bit of pressure on the outside. Treat for shock if these symptoms are there. So what kind of shock symptoms are present in someone experiencing shock?
Cold, clammy skin.
Yeah, cold and clammy skin.
Pulse is weak and rapid.
Yeah, weak and rapid. Yeah, and transport the patient on her side. This could be for many reasons, but one of the most important is also because depending on how large the fetus is, it can put a lot of pressure on her inferior vena cava, but we're going to talk more about that later. But we want to transport pregnant women on her side. Whether that is she positions herself on the side, like on a backboard, or if she's laying down flat on the backboard, kind of put a wedge on the side so that whenever you're transporting her, she's still on one side. Also, in case she vomits, we don't want her aspirating on her own vomit. And then again, reassess. So with reassessment, before we even do any treatment with the patient, we always want to get that baseline vital signs right. Why is that important?
So we know that if anything starts to go wrong, we know that, okay, she was here, now she's here,
Yeah.
she may have decreased in quality.
Yeah, we have something to refer to. So make sure that you're taking those baseline vital signs at the very beginning. So labor and delivery is divided into 3 stages. Stage 1, stage 2, and stage 3. they're all pretty different, but stage 1 is pretty much where the uterus starts dilating, and it ends whenever the baby is completely out. And then the third stage is the delivery of the placenta. We're going to go in depth here. So for the first child, usually, like I said, it's going to take a longer time than for someone who this isn't their first pregnancy. So it's going to start with dilation of the uterus, ends with a maximum dilation of 10 centimeters. Usually whenever we're admitting a patient in a hospital, if they're not at least 5 centimeters or not in active labor yet, but full dilation where the woman can actually be centimeters. And also the intense contractions are going to be 3 to 4 minutes apart pretty frequently. So stage 1 ends with dilation of 10. Stage 2, or we can talk about Braxton Hicks contractions later, but stage 2 is full dilation, and then that is whenever the infant moves through the birth canal. So after the 10 centimeters moves through, baby is born. Sometimes whenever the mother is delivering the baby, she's, like we said before, because of her anatomy, the rectum is located behind, right? And so the weight of the baby can put a lot of pressure on her rectum, which could cause her to feel a need to use the restroom. So we have to make sure that we communicate that with the patient and tell her, we don't want you using the restroom because this usually is a sign of delivery, so we want you to just, just explain to her that it's a normal side effect from giving birth. But going back to Braxton Hicks contractions, these are false contractions that don't mean that the woman is in labor. Usually there's not a reason, or doctors aren't able to find a cause for this, it just happens. But just know this term that sometimes a woman experiences these contractions and she thinks she's going into labor, but they're false. It's really determined by the dilation of the woman as well as the frequency of real contractions. And usually these contractions are going to be painless. But again, we still want to transport any woman that's experiencing any contractions just to be safe, because she needs to be evaluated by a professional with this. We already went over stage 2, right? So what's stage 1?
Stage 1 is the uterus dilates.
Up to what?
10
10 centimeters? Okay. And then stage 2 is the baby moves through the birth canal. So then stage 3 is pretty easy, because all we do is just wait. The woman doesn't have to push. And that is the delivery of the placenta. So again, even when we're delivering a baby, we don't want to pull on the umbilical cord. The placenta is going to deliver on its own in about, depends, but it's usually between 5 to 30 minutes. So just wait for that. Another thing is that whenever the placenta is delivered, we want to put that in a plastic bag with the name of the patient, and make sure that you keep that. That's very important, not only because that's the patient's property, but just in case. Sometimes there can be cases wherever parts of the placenta are still inside the mother, and so we need an OB doctor to verify that it's the whole placenta. So make sure you do that. I don't know if you guys heard, sometimes even mothers keep it and they make like soups and stuff out of it. It's just interesting. Yeah. They sell this cow hair placenta at Walmart. I don't know if you guys have heard of it. No? I used to buy it because it helps with split ends. It's a cow placenta. They sell it at Walmart, but it doesn't, it's like a white sort of cream that you put on your hair.
Didn't Kim Kardashian make a face mask out of hers?
I think so.
Well, I mean, perfume companies actually use whale vomit in their perfumes. So.
I understand breast milk, but how is that?
The placenta has a lot of nutrients, and I mean, it makes sense, but it's still a little gross and weird. So signs and symptoms of imminent delivery. So this is whenever we have to decide whether or not we're going to transport the mother or have to stop and deliver wherever we are, whether it's Walmart or in the ambulance. So when crowning has occurred, what is crowning? Yeah, so presentation of the head or a limb, presentation of any part of the baby. That's the definition of crowning. Whenever contractions are less than or equal to 2 minutes apart, intense, and last 60 to 90 seconds, when the patient feels an urge to push or use the restroom. So this is whenever we are going to stop the transport and just deliver there. So question, what should prompt you to anticipate the need for immediate on-scene delivery? Who thinks it's D? Yeah. Yeah, contractions that are 5 minutes apart, that's too long. Contractions that are 5 hours ago, nope. And then has not had regular prenatal care, nope. Yeah, so she needs to have a bowel movement, because that was one of the signs and symptoms of imminent delivery. So whenever you're on an ambulance, you're going to have an OB kit. I think he has one here, but and it includes, just basic PPE like a gown, gloves, goggles. So you really want to protect yourself. Even though, of course, our priority is our patient, you should still be really careful about protecting yourself and making sure that the fluids don't get on you as much as possible. It's very messy. I haven't done this before, but from videos I've seen and things like that, I've noticed that it's very, very messy. But we're going to want to position the patient on a flat surface on her back. Make sure that you're giving her as much privacy as possible. There's going to be a lot of towels and sheets there, so we want to cover her up as much as we can. We're going to always have someone at the head monitoring her vital signs and making sure that she's okay. You're there for emotional support if someone isn't there with her. Monitoring vital signs again. We should notice that even though, of course, she's pregnant and her vital signs are going to be a little bit elevated, she's also experiencing pain, so don't be alarmed if you see a higher blood pressure, because usually that just means that the woman is in pain. I mean, she's in active labor at this point. We're going to also give her oxygen as needed. When would we give a patient oxygen, just for any patient?
Below 94%.
Yeah, so SpO2 below 94%. And we're going to give her oxygen via the nasal cannula. And yeah. So we're going to watch a video that I think is very helpful, so 1 second.
During a vaginal childbirth, the first stage of labor lasts about 12 to 19 hours and starts when your baby settles lower into your pelvis. In response, your cervix begins to efface or become thinner and dilate or widen. During this time, you may feel strong, regular contractions occurring every 5 to 20 minutes and lower back pain and cramping that doesn't go away. You may see a brownish or reddish mucus discharge, which could be the mucus plug at the opening of your cervix falling out. Your water may break, which can either be a large gush of fluid or a continuous trickle. If you experience any of these symptoms, contact your doctor or midwife to see if you should go to the hospital. At the beginning of stage 2 of labor, which can last from a few minutes to 3 hours, your cervix is fully dilated to 10 centimeters. and your baby's head has moved beyond the cervical opening into your birth canal. During this stage, you will begin to push your baby out. You may instinctively push when you feel the urge, or you may need coaching from your doctor, midwife, or labor nurse as to when to push and when to rest. In a normal delivery, your baby's head will rotate to face your back. During active labor, your uterus is divided into an active segment that contracts, pushing the baby downward, and a flexible passive segment that remains relaxed, stretching to provide more room for the baby to pass through. In some cases, when the top of your baby's head appears or crowns, your doctor may make a small cut, called an episiotomy, to enlarge the vaginal opening. Then you will continue pushing your baby out. As your baby's head passes through the birth canal, it molds into an elongated shape. An elongated head shape will resolve itself within a few days as the skull bones shift back into place. After your baby's head exits the birth canal, his or her head and shoulders will rotate to help the shoulders pass through the birth canal. Your baby's shoulders are delivered one after the other in order to fit through your pelvis. Once the shoulders emerge, the rest of your baby slides out easily. After your baby is born, his or her umbilical cord will be cut. In stage 3 of labor, which may last 5 to 30 minutes, mild contractions will help push the placenta out of the uterus. During this stage, you and your baby may begin bonding through skin-to-skin contact and breastfeeding.
Alright, so that video should be helpful for the next part of this, which is going to be how to deliver the baby. So during this part, pretty much this is whenever the crowning occurs. And what you really want to do is not pull the baby out, not push it back in or anything. Make sure that the woman's legs are spread out. Be really careful whenever you're putting pressure. You don't want to put the right elbow, which is a soft spot, on the baby's head. There's one in the front, the anterior fontanelle, and then the posterior fontanelle. So we have to be very careful with that. Never stick your hands in the woman's vagina unless you absolutely need to. In this case, you kind of have to, right? But whenever the mother is having other symptoms that are for imminent delivery, but there isn't crowning, we don't want to check for her dilation at all. You're not required to know how to do that. You're just there waiting for the baby to come out. Another thing is that we still want to put a right amount of pressure, because sometimes, I forgot the exact term, but it can be a very fast delivery that can be very dangerous for the mother and the baby. It can cause a lot of trauma for the mother. So a very important thing to know is that we still want to control the speed that the baby comes out as slow but as gentle as possible. Sometimes whenever you're at this part of the delivery, I don't know if you noticed, there's like a little gauze there. If you put slight pressure on the perineum, perineum, is that how you say it? Perineum, which is the area between the vagina and the anus, this can prevent tearing. Sometimes they even are going to have to do an episiotomy, which they showed in a picture, which is a surgical cut, in order to allow the baby's head to come out. But if the woman is on epidural, she won't feel any of this until after. But once the head is out, again, you want to really support the head. And you'll notice here that the umbilical cord is around the baby's neck. Can you guys see this? Well, so you'll notice here that the umbilical cord is wrapped around the baby's neck. And why is this a problem? I mean, it looks wrong. Yeah, so use 2 fingers or 3 and very gently put your fingers underneath the umbilical cord and move it over the baby's head. There are some cases where it's so tight that we can't even pull it, so that's whenever we're going to have to clamp and clip when it's around the baby's neck. But that is only if we're not able to put the cord around the baby's head. What else? Also, whenever the baby's head is out, we're going to want to suction the airway. So, do you guys know what a bulb syringe is? Yeah, a little circle thing. So, it's really important that whenever we're using that, we're going to press it, like squish it, and then put it in the baby's mouth and nose. We don't want to do that while it's already in the mouth because we don't want to aspirate. We don't want the baby to aspirate any of the amniotic fluid that's in there. And we're going to start with the nose, or with the mouth, and then the nose. When we're doing that. Whenever, another thing I forgot to mention, whenever the umbilical cord is around the baby's neck, we're going to want to tell the mother to stop pushing at that point until we get it over the baby's head. And so usually we'd want to encourage the mother to pant so that she can stop pushing. She's going to feel like a great need to push, but we have to tell her that the situation and that she's going to have to really work with us so that we can get this baby out safely. So once these shoulders are out, pretty much the whole body is delivered. But again, we want to support the head in the back. At this point, we want to clean the baby as much as we can. The baby's going to have this film over its skin. That's just a protective barrier, so we don't want to take that off or anything. And then again, we're going to start crying. As soon as the shoulders are out, that's when the baby starts breathing on its own. The chest cavity opens up. And so the next part of it, after drawing and all that, is clamping the cord. So we're going to want to clamp at least like 7 inches again, and then we're going to cut straight in the middle. And we really want to have as much of the umbilical cord there as possible, just in case we need to deliver any delivery. Oh, really? Wow. See, because whenever I was in the EMT course, Dallas Regional, they didn't have the L&D clinic, so, or L&D department, so I've always wanted to, but yeah. Did it look like this? How was y'all's experience?
The baby was still in the sack.
It was still in the sack. Yeah, it's actually another thing we should go back. If the baby, whenever you see the head coming out, and if you see that the amniotic sac is still there, you're going to either want to grab like a scissors or anything with a sharp point and kind of cut it, or you can even use your fingers and kind of poke a hole in it. It's so thin that you're actually able to do that. Sometimes the mother's water doesn't break. That's what they mean by water breaking, is that the amniotic sac bursts and the amniotic fluid comes out. So after you clamp, another thing with clamping is that make sure that the baby is at level or below the mother. Why do you think that's important?
Blood flow?
Yeah, because you don't want, the exchange, you don't want it to work against gravity, so we'd want to either set it at level with the mother or below. Another thing, whenever you're clamping, is that, let's say you have the 2 clamps and you're ready to cut, you have to make sure that the umbilical cord stops pulsating. You're going to feel it pulsate. As soon as it stops pulsating, that means that the baby is starting to have its own circulation in its body. So that, like I said before, about 5 to 30 minutes later, the placenta is going to deliver on its own. Again, it's the mother's property. Put it in a bag. Make sure the name is on it. And then whenever we're assessing a infant, you're going to notice that they're going to be pretty blue. I mean, that's normal. The extremities are going to be blue. The body's going to be pink. And as the baby is presented to the environment, their SpO2 level is going to slowly go up. But a good idea would be to provide blow-by oxygen, which is just pretty much grabbing any mask and just putting it over the baby's face. We don't want to put it on the baby's face because it's very uncomfortable for them, and this is actually the best way that they're able to get oxygen. And you'd be surprised how easily the infant is able to take in oxygen, because at this point it has to do with hemoglobin, which you guys don't have to know, but just know that this is very effective for the baby. If an SpO2 level is less than 92%, then that can be very dangerous. So just be aware of that when you're taking an SpO2 level. Usually it'll be on the baby's foot or on their right hand, usually on their right side. Yeah, and at least 10 liters per minute. So I remember there was a question on the National Registry where they asked about this blow-by technique, and I completely forgot what it was, but just know this term, blow-by oxygen. That's how you deliver oxygen to a baby. So for excessive blood loss, I'm going to go ahead and turn the lights. So there's something called the fundal massage. So whenever the mother, like after delivery, she's going to be bleeding a lot, and sometimes it's excessive. So what we're going to do is provide this massage, which is pretty much just massaging the uterus. After the baby is delivered, you can still feel the uterus on the mother. It's kind of like a grapefruit size, so it's not that hard to find. And I'm going to show you guys a video of how it works, but it's just pretty much you're putting pressure underneath the navel and then massaging it in a circular motion. There's different ways of massaging it. Give the mother oxygen, treat for shock, which is just providing. What else? And I'll show you guys a video so you guys can see how that massage works, because I've heard of different ways. There's like one where they actually go inside and they touch the uterus and they massage it that way. But in this case, you want to do an outside fundal massage. So I'll show you guys the video of how to do that.
Go over there.
To perform an external uterine massage, first the lower hand is placed in a cupped position over the lower uterine segment just above the pubic symphysis. The upper hand is then placed at the uterine fundus, thereby positioning the uterus between the examiner's hands. The uterine fundus is then massaged gently in a rotating fashion with the upper hand, while the lower uterine segment of the uterus is supported by the lower hand. Upon massage, the uterine muscle is expected to contract and will start to feel very firm. After uterine massage, once again examine the perineum for bleeding and clots that may have been expelled.
Okay, so does that make sense? Yeah. Okay. Alright, so now we're going to go ahead and pause. We're going to talk about the antepartum emergencies, so you guys can take a break. I know it's going to be a long presentation, so I want you guys to be aware and alert. So.